All right, we'll get started now. So good afternoon, everyone. Thanks for joining us for today's South Texas Regional Family Medicine Grand Rounds. Next slide, please.
Oh, sorry about that. Let me get there.
It's all right.
Oh no. All right. Here we go.
Thank you. All right, so thank you everyone for muting your microphone once the presentation begins, leaving your cameras on and being attentive to the presenter and engaged in the session, and also completing and submitting a session eval form. And I'll put that eval form in the Zoom chat throughout the presentation. Next slide, please. So I'll leave this up here for a little bit. This is the activity code for today's Grand Round session to get your CME credit. All right, next slide, please. And this is just more information regarding how to get that CME credit via text. So I'll leave this up here for a little bit as well. All right, next slide, please. And then this is just information regarding CME transcripts. All right, next slide, please. And then this is just information regarding the AAFP credit system. All right, next slide, please. And then this is just about the core competencies. All right, next slide, please. So Dr. McGeary has no financial relationships with ineligible companies to disclose. Next slide, please. All right, Dr. McGeary.
All right, thank you. So thank you so much for having me come speak with you today. I'm Cindy McGeary. Oops, and I'm blowing through slides. Let's try that again. I'm Cindy McGeary, and I am an associate professor and a psychologist in the Department of Psychiatry. I also am the program director for our clinical psychology internship training program. And I want to also introduce, even though they're not here today speaking, Dr. Emily Wang, and she is an associate professor and the associate program director for the internal medicine residency program. And also Dr. Tabitha Blunt, who is an associate professor and a part of the clinical psychology internship training program. She's the associate training director. And we all work together, and this training came about because our psychology residency DEI committee received a small educational grant from the Association of Psychology Postdoctoral and Internship Centers to conduct a training with our psychology trainees and faculty, as well as develop an internal policy to address patient mistreatment of our trainees. I'm going to share some of the information regarding the workshop, and as well as discuss the development of our own policy that we utilize within our own training program. Emily and I were AES fellows while this grant was funded, and we combined some of our data for this presentation. She was doing a very similar project within her internal medicine residency program. And I really just want to start out by saying that if you don't work with trainees at this time, you'll still benefit from this presentation. The skills that we discuss can be applied to any provider or staff member who works either directly or indirectly with patients. It can also be applied to coworkers and colleagues as well. And so I think the skills are really universal, even though the presentation is very focused on trainee mistreatment. And so here are our learning objectives for the day. Folks will be able to identify the prevalence and impact of trainee mistreatment, You'll be able to identify potential barriers to managing mistreatment of trainees by patients. We are going to describe the components of the erase model, and then we're going to apply those to vignettes, which is always kind of the uncomfortable part, but I'm hoping folks will really enjoy it. But really, before I get started, I like to always ask, why should we focus on this? Why is it important? And please feel free to speak up, or I'm also monitoring the chat as well. Why might it be important to look at this? I'm trying to warm you up for the harder questions later on. Mental well-being, absolutely. Trainee well-being overall, absolutely. And so it is really important for the mental well-being and trainee well-being. There's research that shows that it absolutely impacts that. Professional fulfillment, absolutely. Learning boundaries and management of situations, yes. We don't always get that, I think, in our professional training. It's like a trial and error. And so I think learning those boundaries early on, especially as trainees, can be really important and empowering. So thank you for that. So here's an overview of what I'm going to be discussing today. I'll go over a literature review, some of our local data that we have that's from both our psychology internship training program and from the internal medicine residency, the erase framework, some practice, and then the policy. I'm going to start out with a lit review. So the majority of the literature that we found on this topic really focuses on physicians, psychiatrists, and nurses. And when we look at it, we find that nearly 60% of responding physicians have experienced biased comments from their patients. And that includes remarks on race, gender, religion, age, and weight. And it's been found that women and ethnic minorities were most likely to report this type of verbal mistreatment. 50% of physicians had patients request a different provider based upon a personal characteristics such as gender, ethnicity, or race. And over 50% of the physicians reported having a really strong emotional reaction to that. We know that acts of discrimination can be harmful to healthcare workers and leads to distress and burnout. And so that goes back to that trainee well-being. In the immediate wake of these incidents, learning has been found to at least temporarily stop, which is why it's also really important to be there and support our trainees through these situations. Little guidance exists to help trainees and supervisors address these type of behaviors. Due to lack of training on how to respond, individuals may experience anxiety, guilt, or self-disappointment if they don't have like what they consider the appropriate reaction or comment back to it. Residents and faculty may also want to confront their aggressor, but they may experience a freeze effect just because they're in shock based on the situation. And that can be jarring and causing an inaction. And this could lead to rumination and negative self-evaluations regarding the event. And there's a wide range of possible outcomes regarding trainee mistreatment that can range from no effect, people are able to brush it off and move on, to having anxiety and anger, all the way to leading to changes in career. The outcome of microaggressions are very similar. Microaggressions have been found to increase stress in the lives of people of color, lower emotional well-being, and cause increases in depression and negative feelings, impede learning and problem solving, and impairs employee performance, and just takes a toll overall on the physical well-being of individuals. It can be difficult to respond to microaggressions because we're also expected to be professional and trying to figure out that balance and that boundary. And the impact of microaggressions can include anxiety, depression, binge drinking, and poor academic performance. So learning to address mistreatment during a patient encounter can build self-efficacy. And active coping strategies tend to be associated with greater well-being, and this includes increased feelings of competence, self-esteem, and psychological well-being. Bystanders often feel better about themselves when they confront their aggressor as well, and targets who choose not to respond may feel guilty and engage in rumination. And so before I move on to the next slide, I'm wondering what might be some of the barriers to addressing mistreatment when it comes to trainees or even with peers, colleagues. What might get in the way or make it more difficult, especially in a work setting? No experience, absolutely. Super uncomfortable. Perceived as being unable to manage the situation. I think that's a great response is that we want to always do what's absolutely right and perfect. And sometimes that doesn't always occur. And that can cause us a lot of distress as well. And feeling comfortable to be open and honest, I think that can be really hard as well. So definitely those are some of the reasons why we might not address trainee mistreatment or mistreatment in general. And so some of it is a clinical care priorities. And I think some of that does fall into wanting to feel as though they've managed the situation professionally. Sometimes we have remarks from patients that we're not certain in the moment would really be helpful to respond to. And so is it helpful? Will it make a meaningful impact if you're having this long discussion about why it's not appropriate to make these remarks when you're dealing with an individual who is intoxicated past the point of even being able to remember the conversation later on? Lack of skills or uncertainty about the appropriate response, what's preferred, not just from our own responses of what we think is right, but also from the organizational responses, like what are we supposed to say based on our work code and our guidelines within our clinic. Lack of support, maybe not feeling like it would matter. Lack of that knowledge of the institutional policies, fear of being unprofessional. And then sometimes some folks just feel like it's too high of a burden. They just don't have the energy to do it. And so they just decide that they're not going to put themselves in that position. And so now I want to focus a little bit on some of our local data. So to start with, this is some data from UT's internal medicine residency. And so it's interesting comparing to the national average, our UT internal medical residents reported a higher occurrence of both witnessing and experiencing mistreatment. Some by only about 10%, but others by 15 or more. And so it definitely is occurring, and it's not uncommon, unfortunately. And so this slide here shows that the majority of residents had both received an offensive remark and or heard an offensive remark about another healthcare provider. And so Emily took this survey an interesting step further to determine where the mistreatment was most likely to occur. And as you can see, the offensive remarks, including age, gender, ethnicity, race, weight, accent, appearance, medical education, and sexual orientation were the categories that she looked into. And in many of these categories, to include comments about gender, ethnicity, race, religion, and accent, it occurred primarily at the VA. Do any of you have any thoughts about why that might be the case? Why these sort of statements are occurring more often at a VA versus UH? Psychiatric comorbidities, I think that makes a lot of sense. Patients are older, yeah. And then PTSD components added into it. I think sometimes just overall like a military culture of being primarily male, older white men could have an impact on that as well. So absolutely, thank you. So here is a graph from the internal medicine residents demonstrating what the residents did when mistreatment occurred. Most handled it themselves or discussed it with family, friends, or fellow residents. But I think what was really concerning about it is that very few ended up reporting it to a supervisor or anyone in leadership. And so it never even got raised to the level of, being able to be discussed on more of a clinic level or how it impacts, institutional policies or leadership in that way. Most of them felt like they were just going to kind of deal with it on their own or kind of their close social circle. And so now I'd like to discuss some of the data from our psychology residency program. We conducted 2 needs assessments within our program prior to developing our training. And the first targeted our internship training faculty, and the second targeted 2 consecutive internship cohorts. And so we have anywhere from 10 to 12 each year. And so I think we had about 22 who responded. And so I'm going to start by discussing some of the faculty responses. And so based on this slide right here, more than half of our faculty, which really has a really broad age range from very new psychologists to very late career psychologists, more than half of the faculty reported several instances of provider-directed discrimination by a patient, and most often it occurred more than once. And this slide addresses how competent our faculty felt to address that mistreatment. And so it ranged from very competent, 14%, which is wonderful, to somewhat incompetent, 7%. Receiving, and then with this, whoops, I'm sorry. So it's 14% felt very competent, 7% somewhat incompetent, with most of it being kind of in the middle with somewhat competent if you ignore the 42% that didn't respond. And so while there weren't anyone that felt very incompetent, there were definitely folks that were maybe not completely sure how to address this. And the majority of the faculty, about 96%, reported that a development of a training and a policy to address these type of behaviors was relevant to their experiences as a supervisor. There we go. So here is some of the data related to our cohorts of psychology trainees. Although they were still really early in their careers, approximately 20% of our interns had already experienced provider-directed discrimination from patients. And unfortunately, those trainees who reported patient mistreatment reported that it had occurred on multiple occasions. And so this information isn't on the slides. However, we asked the faculty who experienced provider-directed discrimination if they felt supported by faculty, staff, and leadership regarding this discrimination. And about 50% reported feeling satisfied or very satisfied with the support that they got. And then only about 10% felt really dissatisfied with the support they'd received from the organization. The interns, however, largely reported feeling either neutral or dissatisfied with the support they received from their supervisor at the time. And so it's interesting, our supervisors are saying they don't really know how to respond in some cases. And they have maybe a misrepresentation of how the organization supports in these situations where they were feeling more supported. Interns, however, were really not feeling very supported at all. And so I want to discuss the ERASE framework. This is really leads us to having a framework to address these types of behaviors. And the techniques that we're going to discuss are not all inclusive or appropriate for all groups or all situations, but this really is an attempt to provide training and rehearsal of techniques that may be used in the moment. And I think that's where we need a lot of practice because sometimes we're not prepared in the moment. It's like having those conversations where you have arguments in your head where you're coming up with all the really good things you would have said well after the fact the conversation occurred. It's kind of like that. But if you're a little more prepared and you practice in the moment, it's much more likely that you'll be able to address these types of behaviors. And so I'm hoping that this will encourage discussion at your own clinics about how to address these types of behaviors. And so the ERASE framework was developed by Goldenberg, Cyrus, and Wilkins to address patient mistreatment of medical school trainees. And it's an acronym. The E stands for expect, and it's that you should expect that these type of situations will occur, so that you can be prepared. The R is for recognize, so recognizing the mistreatment when it occurs. A is for address the situation in real time. The S is for support the learner after the event. And E is for establish or encourage a positive culture. And so expecting that the mistreatment will occur allows practice of scenarios before a situation arises. Being prepared increases that likelihood that a supervisor or a trainee will be prepared to address it in the moment. And I think supervisors should really try to be proactive and discuss with trainees how they're available to intervene or provide support to trainees if an event occurs. And ideally that should happen well before an event occurs. So a proactive approach helps to reinforce a culture of mutual respect and allows trainees to have a safe outlet to report patient concerns. And so you might be able to say something to the effect of that I believe to learn and care for our patients for the best of our abilities, we all need to feel comfortable and supported in our work environment. And I wish that microaggressions, harassment, and discrimination didn't occur, but it does, and you may experience it with our patients sometimes. Patients may say things that reveal their biases, and sometimes I may also inadvertently be the source. And so I'm really hoping that we can discuss these occurrences during our supervision. I want you to let me know when you are not feeling comfortable or supported. And so I'm wondering, have any of you been in a position where you've had these type of conversations with your trainees or learners? Is this something that you routinely do or would just consider doing in the future? How about first we start with, is this something that you do with your trainees or learners now? I'm checking the chat for a yes or a no. Have not done this before regularly. Is it something that you might consider doing in the future, to have that kind of conversation as you're starting to meet your trainees and learning from them as they're learning from you, to kind of set a precipice of, this is how we might want to move forward? So yes, so thank you.
I think I haven't.
Go ahead.
No, I haven't done it yet, but I think it's, and at this point as a resident, we have medical students with us. We can incorporate that. I guess going forward, yes, it's definitely a thing we can do. And
Absolutely, thank you. And I think it's something that's nice, especially if you're doing it like, and someone put in the chat for good for orientation, which I think is really wonderful, because I think sometimes it's easier to have those conversations before an event happens, because once something happens and a patient has been awful to someone, tensions are high and you're feeling overwhelmed. And a statement like that might not hit the mark as well as it would if you started out your relationship with that individual in that way. And so to give a little bit of background of why I'm so interested in the topic, this isn't related to patient mistreatment. It was actually a colleague who did it. And so I was doing orientation with my psychology interns. And so I had a class of like 11. And this was the first year that we'd had all females. And so it was 11 female interns. And so I was giving them a tour of the School of Medicine. And so I had just taken them by Starbucks, which is like really important, to show them where that was. And we were heading back to the elevators to go up to our orientation room. And as we were sitting there waiting for the elevator to arrive, an older white male physician in his lab coat came by, and he kind of looked at a gaggle of us standing there waiting for the elevator, and he said, "Oh, wow, like, are you all going to a beauty pageant?" And I just like stopped. I was shocked. I was like frozen into inaction. I was like, oh my gosh, what do I say to this? And unfortunately, I was just caught so off guard that I didn't say anything. And so we went back up in the elevator to the orientation room. And I had to ask, like, oh my gosh, did you Did you all hear that? And it was about a third of them that were like, yeah, I heard it and I didn't like it. Like that was not appropriate. Another third, didn't really hear anything. It was like one of the first days they were just chatting with their classmates. And then another third were like, yeah, I heard it, but I thought he was just making a compliment. I just didn't think much of it. And so thankfully later that day, we had our Title IX coordinator coming in to do his presentation. And so I kind of cornered him a little bit in front of the class and said, like, this is what happened. Like, I was kind of shocked and didn't say anything. Like, what could I have said in that situation? What should I have done? And he was really helpful. And he said, I'm sorry that occurred. What you might have been able to say was something to the effect of is like, well, we're not going to a beauty pageant, but we're going to do a lot of really great clinical care this year, or we're going to do a lot of great higher education learning, and like really kind of put the focus back on what these individuals were here for, which is their training and learning, which was just such a simple thing to say and really kind of, I think, hit the mark. And I think that's why I'm so impassioned about this, just because I was in a position where I just felt so horrible because I didn't say anything and knew that I needed to in that moment, because I wasn't expecting that something like that could have happened. I just wasn't prepared. And so I think just having a little bit of forethought about how these situations occur and how you might react in them can be really helpful. And it doesn't have to be, the comment doesn't have to be like a complete smackdown. It can be really something that redirects someone onto really what's more appropriate rather than the looks of these interns. And so when it comes to recognizing, I think that's oftentimes much easier to observe and react to that really aggressive, overt discrimination. Sometimes it's a lot more difficult when the discrimination is more ambiguous, it's open to interpretation, or it's difficult to recognize. And I think it's really important, especially in the terms of microaggressions, is that, when a supervisor is a different demographic than the trainee, to recognize that they may be less likely to recognize a microaggression when it occurs. And so I think as supervisors, we have to be really open to the possibility that the trainees' experience absolutely differs from our own, and to really be open to hearing about their experiences and how they heard a comment. And I think supervisors also need to be really in tune as much as possible with the trainees' nonverbal cues and their body language and affect, because they might not feel comfortable saying something right out in the open, but if you're in tune with these other nonverbals, you can generally pick up that, wow, something that was said didn't sit right, and then you can have a conversation with them after the fact. And so as we look at the address part of the model, we know that supervisors oftentimes lack guidance on how to address racism, sexism, heterosexism, ableism within the context of a professional and supervisory context. But we really know that if the mistreatment is not addressed in the moment with the patient, we understand that sometimes it's just not appropriate. Like sometimes there's not time, there's other things going on, but it is really important to try to get back with the trainee after the fact and have discussions about that encounter. And according to Sue, who's done a lot of research on in multiculturalism, is that the purpose to intervene is really to provide that validation to the learner, to show them value as a person, affirm their racial or group identity, and provide support, encouragement, while providing reassurance that they're not alone and that you're there for them. And so there's a lot of things though that you have to consider within a professional context, especially when it's a patient, when you think about addressing mistreatment. And so some of the things that you really need to think about is that clinical context. Is it inappropriate? Is it at the front desk? Is it in the waiting room? Is it in the clinic room? Where is it occurring? And what is that relationship? Is it someone that you may never see again? Or is it someone that you're going to work with continually? Because that might also impact how you want to address it, as well as the goal. If the goal is to just stop the behavior immediately, you might have a different response than if you were hoping to maybe educate the patient and bring them around to a different way of thinking. You also have to think about the tone, which is best suited for the response, which is also very tied to the goal. The patient's condition, I already talked a little bit about. If someone comes in who is on substances that might not be aware of even what's going on, is that the best time? And then also your own reactions, which I think is unfortunately sometimes the last thing we think about, but should be much higher on the list. I think we put our own reactions to some of these situations lower down because we're trying to be this professional that is, able to let these things roll off our back and move on and do the rest of our job. But I think it's really, I think it really does us a disservice to not recognize that these things impact us as supervisors, as trainees, as learners, as staff. It's just as people that these have an impact on us. And if I know that sometimes when I'm feeling really revved up about something, I want to react, but maybe that's not the best time for me to react and say something because I might not say what I should say. And so further with the address part of the race model, addressing that mistreatment sometimes just interrupts the moment. And so the behavior will stop occurring. Sometimes it's just surprising to the individual to hear that someone is going to actually say that this is not okay and won't be tolerated. But it does require that reflection and action. And that is absolutely what I was lacking in the story that I was telling you, is that you have to be both processing and responding to an unexpected comments, and that can be really difficult. So that's why it's so helpful to have that plan in advance. And I always like that when supervisors follow up with the trainee afterward to make sure that the trainee is doing okay, or if they need other resources. We've had an intern in the past who really had a very poor interaction with a patient who we ended up providing resources for psychological services after the fact, just because she was really thrown. It was one of the first times it had happened in her career and was really having to process some of it. And so just making sure that you're there for that learner to make sure that they get what they need. And so here are some strategies on ways to address, once again, knowing that these aren't perfect in all situations, but at least give you some ideas of maybe what you can think about on how you might be able to address some of these circumstances. And so you can appeal to values. This tends to work best for people who are lower in prejudice. Highly racist individuals tend to have no problem with their values. And so you might be able to say something like, I didn't think you were the kind of person to think that way or make assumptions. You can express your emotions of hurt or disappointment and say something like, I'm hurt, disappointed that you feel that way. And this tends to work better with individuals that you know well. And it can allow for some perspective taking and create some empathy. You can ask the individual to explain. What do you mean by that? Acting confused can allow the individual to provide more information. And the trainee supervisor maybe have an opportunity to provide some education. And so you can just say something like, can you explain what you meant by that statement? You can emphasize with the underlying feeling. This tends to work really well with highly racist individuals. You can say something like, I understand that your situation is difficult, but we don't tolerate those type of comments. You can provide new information. I find this one's a little bit harder for me because I'm not a walking bank of data. I really have to think through what I'm saying, but you can provide data or stats to the individual that contradict a statement, but it does require a lot of preparation ahead of time to make that data informed statement. You can use humor. This tends to work better with folks that you know pretty well. And so you can say something like, wow, you sound like that proverbial uncle at Thanksgiving dinner. And there's also just nonverbal responses. And sometimes a look or a sigh can be really impactful without requiring a high level of preparation or energy. So you can use a sigh or a firm stare. So trainees will react differently and require different levels of support when these sort of occurrences happen. You definitely want to acknowledge that the encounter occurred. And sometimes just sharing some of those reactions about the incident can be a great way to open up dialogue. And I think team debriefings can be really nice. And I know we're all really busy, and so sometimes that can occur, but it does reinforce that mistreatment will not be tolerated. And it really provides a safe space to talk about some of these difficult conversations, but it also allows for some problem solving for the future in case it happens again, of how your clinic might want to address it in the future. But supervisors should always still follow up with their trainees in private afterward to make sure they're doing all right. And so something that you might be able to say is just, that was a difficult encounter. How are you feeling? And so that just that really simple check-in can really mean a lot sometimes. You can involve the trainee in the decision-making about next steps. And so I can understand how continuing with Mr. Z could be difficult. We have a couple of options here. I'd like to get your input on which one feels right to you. And you can encourage reporting incidents and empower trainees to speak up. And so I want to hear when things like this happen. It's important that everyone feels safe and comfortable here. And then we move into the establishing a positive culture. So we really want to try to encourage and initiate, invite, instill framework utilized in the literature on cultural humility. So you want to initiate conversations about identity and cultural diversity and invite supervisees to engage in that ongoing cultural dialogue while instilling the value of cultural humility and provide a safe space to have those respectful conversations. But it's also really important as supervisors for us to seek out didactics, workshops, and training activities that allows for discussion about discrimination, because having those opportunities and practice makes it easier and makes us feel more confident about having those difficult conversations in the future. We also want to establish a positive culture by addressing mistreatment and supporting team members and trainees. That sends a huge message that we don't accept the mistreatment, and that's not the culture that we want within our clinics. And we also know that leadership really does need to play a role, and it needs to be kind of a top down to the bottom scenario where our leadership also has our backs. And programs should provide trainees with information about mistreatment and identify individuals that they can go to for support. And if they have different channels for reporting these sort of in situations, it's really important to have that available to them. And so I'm going to get started with some of the practice, but I always like to ask at this part, because having given this presentation several times over the past year, there have been a lot of instances of staff and faculty with their own experiences that they haven't shared with others. And maybe it's the idea that this is just part of the job and they don't seek their own support. But I think it's really important to reflect on some of these situations and recognize that they occur. And sometimes just having like a community to talk to about these things can be really nice, to recognize that this is a difficult part of our jobs that we encounter. And so I'll give it just a moment or so if anyone feels like they have had one of these situations where like, man, this was awful and this is what I did. And maybe I did it right, maybe I did it wrong, but this is what happened to me. All right, it is quiet. So I'm going to go on and move to the practice scenarios that I have put together. All right, so the first problem is derogatory language. And so you sound like an F. I don't want any N, doctor, or you're a B. And so really overt discrimination. How might you react to patients making these type of remarks? What might you say to them? You can put it in the chat, or if you want to say it out loud. If a patient said this to you or one of your learners, how would you respond?
I think you have to respond that that's, unacceptable. We don't tolerate that kind of discrimination and language here. I mean, I think you have to respond in those situations pretty assertively.
Absolutely. Thank you so much for that. I completely agree. And so you have to, when it's so overt and it's so in your face, you just have to smack it down right away and set some very clear limits. And so what you said was absolutely appropriate. Some other options are we expect both patients and providers to be treated with respect in this clinic. We cannot tolerate that kind of language. That type of comment is inappropriate, and please refrain from speaking to our staff that way. And so you're absolutely right. It can be short and sweet and just no, this is not okay. So wonderful. Thank you. The next one is a microaggression. Oh, I'm sorry. Let me also read the chat. So we have Dr. Abide, that type of language will not be tolerated here. Another comment is, I am here to help, but we have to be respectful to each other in this encounter. I like that a lot. I was giving this presentation to a different department a few months back, and one of the providers said, I don't know if this was right or not, but we had someone in our room who was just being awful and rude and angry and being disrespectful. And she said, I stopped the encounter and said, I am here and I want to help and I want to listen to you, but I can't help you right now when you're saying these things. And so I'm going to step out for a few moments and let you collect yourself, and I'll come back, and I'm hoping we can move forward from there. And so really setting that boundary of trying to be both professional and doing our jobs of caring for individuals, but also saying, I'm not going to do it in this situation. Okay, so the microaggression practice. So a patient repeatedly addresses a female resident by their first name, or a patient asks a student of color if he is ready to take the patient's lunch selection. How might you respond in a situation like that, in either one? It's a little bit harder, right? It's a little bit harder when it's not so straightforward. Of like, wow, they just can't say these things. They still shouldn't say these things either, but it feels a little bit different. Yeah, I think that's very, go ahead.
When I'm just called by my first name or not doctor, I guess it doesn't bother me, so I don't really do anything about that.
I think that depends on preference, right? I think there are some individuals who feel very strongly about being called by their title. And I think especially if they were in a room where all the males were being called by their title and you were the only female doctor and not being called by your title, it might feel a little bit different than just a patient calling you by your first name. Yeah. And so please refer to me as Dr. Such and such. And there's this response to the second comment should be treated as the first case. And so you can definitely move over. You can definitely provide kind of that education or explanation. You can also just make a straightforward statement of like, please refer to me as such and such. If I was a supervisor in a room and this was happening to one of my trainees, I'd probably say something like, actually, this resident is a doctor and her title is Dr. So-and-so. Or I'd say this resident is not here to take your lunch order. He is your doctor. He is your physician. And so clarifying, educating in a nice way, but also making it very clear that is the case. You guys are doing great. So I know this is a little bit difficult to see, but I'm happy to share my slides, and there is the reference off to the left is a microaggression response toolkit. It's really nice, and it has a lot of different scenarios and what you might be able to say in those scenarios, which I think is really helpful, once again, to just read through to get a sense of like, wow, if this occurred to me, this is what I might say. Or in some cases, it might be, if this occurred to me again, this is how I might react. And then here is our last practice. And so these are complimentary comments. These ones can be sneaky because the person making the comment very likely thinks that they're actually providing a compliment and that they're being nice. And the example is, I'm so lucky to have such a pretty doctor, or I'm so glad to have an Asian resident. You're all so smart. And so something that on the surface, like, feels like it's supposed to be nice, but we know deep down that it's not. How might you respond in a situation like that? Or if this has occurred to you, how have you responded in the past to it? This one may be a little bit of a head scratcher. For time's sake, I'm going to go ahead and just say you
I
can
would
do some
probably just-
redirection. Oh, go ahead.
No, that's what I was going to say is redirect and say, you know, I don't know about that and we don't need to discuss that, but I am here to take care of you. Again, just shift the focus and kind of minimalize what they said.
Absolutely. And that's wonderful. And so just a lot of redirection or reframing, like pointing them off to a different direction. And so you can say something to the effect of like, all of our residents are very skilled with high levels of training, and then just moving right along. And so that could be used for either scenario. And then all trainees are equally competent in the chat. Absolutely. Wonderful job. So this next slide talks a little bit about the policy that we developed for our psychology training program. And so it's taken from a policy that was developed by Duggan, White Davis, and Tattleman. We revised it to fit our training program and our clinics. Do any of you at this point in time have a clinic policy on how to address discriminatory patient interactions? I know we often see like the patient bill of rights of what the patient's rights are, but sometimes we don't see maybe what the provider's rights are. And we also, when we tried to put together this policy, we recognize like we're a program that varies across clinics. And so it's really hard to have something that can be very clinic specific when it's across like a broad spectrum. And so we really spent a lot of time having folks go over from the different clinics that we are in, looking at this. And so it's loose enough that it can be open to interpretation, but it's still tight enough that gives our supervisors and trainees kind of an idea of what to expect when these situations occur. And so you'll see the QR code. If you click on the QR code, as long as it's working right, it'll take you to our psychology internship training page. And if you scroll down about halfway down the page, you'll see our diversity policy, and it'll bring up the form if you click on that. If it doesn't and you want to see a copy of it, shoot me an email. I have it at the end of this presentation. I'm happy to share it with anyone. If your clinics are wanting to consider something like this, or if you're wanting to do training with your own clinical staff, I think it can be really important to have some of these conversations. And so when we started out, it was saying is that when a racist or discriminatory interaction is directed at an intern by a patient, the intern, first and foremost, we want them to discuss that incident with their supervisor or their treatment team in the moment, or as soon as possible after the incidents occurred. And then it's the supervisor's responsibility to support the intern involved in establishing a clear position that racist discriminatory patient behavior will be addressed and is not okay. We ask that our supervisor will then facilitate a discussion to plan an appropriate strategy for addressing the patient's behavior and invite dialogue, having the intern involved in that. And so if the intern wants to, they can be part of that conversation, but we don't make them in case, especially if they don't feel safe in that situation. The team will discuss the harmful and unacceptable nature of the patient behavior, and it'll allow the intern to discuss their own reactions to it. The supervisors will accommodate wraparound support for that longer term care. And so following up afterward, the team will then clearly state that the involved intern is a vital part of the patient's treatment team if we're able to address it in the moment in front of the patient. If a patient requests a provider due to a discriminatory character, like a characteristic that could be deemed as discriminatory, we ask them that they really need to clarify why they want a new provider. And we don't give them a new provider if it's because, let's say, they want a different provider because of the gender. Now, there's a little bit of work with that. We do a lot of PTSD work. And so sometimes it is kind of natural, I think, for like a sexual assault victim not to want to have a male provider. And those, I think, have a lot less to do with racist thoughts and discriminatory behavior versus just a fear-based need. And so we're much more likely to allow that versus other reasons of, well, I just don't think a woman could help me kind of thing. We want our supervisors to convey that accommodating patient requests is not acceptable. And and that we will use our clinical judgment, especially in those cases if it's something outside of a discriminatory racist behaviors, and discuss what the treatment team is encouraged in order to determine what's the optimal decision and the benefit for the intern, patients, the team members, and the clinic. And so sometimes that might be, if an individual doesn't want to be seen by a certain member, is they might be referred out. The patient and the team will discuss care moving forward, but really the onus of that ends up being on the intern. And so if an intern is uncomfortable continuing to see that patient, they have the right to say so, and a different member can be found to treat that patient. And I know that can be really hard for learners to sometimes say, because they don't want to look unprofessional, or they don't want to worry about how that might impact their evaluation. And so we actually put in our policy that this will not impact their evaluations. Oh, let's see. Sorry, I'm trying to also keep up with the chat. If a patient prefers a different provider because of racism, I understand not giving. Yep. Given the opportunity when caring for a patient that has been racist. Okay, so you get your question answered. Wonderful. And then regardless of any decisions that are moved forward, we want our supervisors and our interns to not only report these sort of instances with their direct supervisors, we also want them to push it up to leadership. And so as a training director, I want to hear about it as well, so that I can also provide follow-up with that trainee and make sure that they're doing well. And then what I do as a training director is I also keep note of these occurrences so that we can discuss it in our yearly faculty meetings and make sure that our policy is hitting the mark, or if we need to revise it or make any changes. And so it's kind of a long explanation of our policy that works well for our training program, knowing that might not work for yours, but that it is definitely worth having the conversation. And so I also want to be mindful of time. And so these are my references, but I want to get to my end slide that has my contact information. I want you to know that if you need to reach out, if you need a copy of the policy or would like to discuss it, please feel free to reach out to me at any time. I'm happy to share it. But this also allows a little bit of time so that I can address any final thoughts or questions that you all might have.
I just want to say thank you for giving this presentation and continuing the conversation that is so important, particularly in graduate medical education. Thank you for giving us some tools to start.
Absolutely. And I think it is something that is so true, that it does take practice, because boy, it can be uncomfortable and it can be hard. But if we shy away from those conversations that are really difficult, it just makes it worse. It just makes it so that we're completely unprepared.
Absolutely. And I think normalizing that even as faculty, we may not feel completely competent, right? And so it is also our duty to learn how to do better so that we can provide better support for our residents.
I think that's so true. And I think you make a great point of being able to say that, like, that feels shameful, right? For us as faculty to say, oh, I don't know if I know how to handle this. I don't know if I'm competent, because we feel like others look up to us and that we're very, very professional and we are very good at what we do. And to be able to say, like, oh, I'm not prepared in that area feels bad. But I think it can also be really wonderful to model that sort of behavior so that our learners also know that I don't have to know it all either. We can work together to find solutions sometimes.
Absolutely. Thank you.
Absolutely. Any other last thoughts? Yes, please feel free to share the microaggression toolkit in the link. Absolutely. All right. Well, thank you so much for inviting me, and thank you for your time and attention today. I know it's when anyone starts a presentation by saying that there's going to be vignettes, there's always kind of an internal cringe that happens, and I totally get that. And so I'm really thankful that you were all willing to participate. All right. Thank you. I hope everyone has a wonderful day.
Thank you.
All right. Bye.